today we're undertaking a deep dive into an inherently profound and I think challenging area, the diseases of infancy and childhood.
It's pediatric pathology.
Yeah.
We're going to be tracing the unique trajectory of human health from, the moment of conception all the way through adolescence.
And it is such a critical topic. I mean, the stakes just couldn't be higher.
They really couldn't. Children are not simply small versions of adults. Their physiology, their developmental pathways, their reactions to disease, all of it is fundamentally different.
Right. Our sources really emphasize this idea that this field is a world unto itself. It's governed by its own unique rules.
And the health outcomes that are established in those first few years, they often dictate the entire future for that person.
So let's unpack those stakes right away. Let's look at the hard data, particularly here in the United States. We have seen some tremendous public health successes over the past several decades. If you look at the U.S. infant mortality figures, we saw a staggering drop. I mean, it went from 20 deaths per 1,000 live births in 1970 all the way down to 5.8 in 2014.
And that's a testament to so many things. Vaccination, better neonatal care, screening.
It is. But while that progress is monumental, the source material gives us two immediate and pretty sobering realities.
Right. The first one is that despite all that success, the United States still ranks poorly. I think it's a disappointing 30th among high-income Western nations in infant mortality.
30th. And second, the disparities within the country are not just wide, they are jarring.
Absolutely. The mortality rate for African-American infants is more than double that of white American infants. We're talking 11 deaths per 1,000 live births compared to 4.9.
And when you see a clinical outcome that's so profoundly divided along socioeconomic and racial lines, it immediately tells you that we're dealing with issues that go much deeper than just, molecular or cellular pathology.
Oh, absolutely. We're dealing with foundational inequities in access, in care, in maternal health. All of this precedes the birth itself.
It shifts the problem, doesn't it? It goes from being a purely biological failure to a failure in how we deliver equitable foundational care.
That's a crucial insight.
And as we move past those initial survival challenges, the threats, they shift entirely. This is a major theme in our source material.
It is. In the first 12 months, that's the neonatal and infancy period, the risks are overwhelmingly internal and biological.
Things like congenital anomalies, prematurity, low birth weight, sudden infant death syndrome, SIDs.
And complications that arise from the mother's pregnancy. But once the child clears that first critical year, the landscape changes completely.
Right. For children aged 1 through 9, the leading cause of death becomes unintentional injuries. Accidents. And that's followed by congenital anomalies, maybe the ones that were initially subclinical, and then malignant neoplasms cancers.
So the shift from this intrinsic failure to an extrinsic danger is complete.
And as the child approaches adolescence, the risks become even darker. In the 10 to 14 age group, accidents are still number one. But then we see this disturbing rise in non-natural causes.
Malignancies, suicide, homicide, and then congenital malformations again.
The whole progression, it just reflects the growing complexity of life, transitioning from purely biological fragility to these behavioral, social, and environmental vulnerabilities.
So our mission today is to dive deep into these unique stages. We'll navigate the specific conditions, we'll dissect the precise molecular mechanisms, and critically, for a deep dive based on pathology sources, we're going to interpret the visual evidence.
The diagrams, and especially the microscopic H&E slides that pathologists use.
Exactly. We need to grasp not just what happens, but why these conditions manifest only in this developing pediatric population.
Okay, let's unpack this, starting right where the problems begin, with the defects that are present at birth, the congenital anomalies.
Right. So we define congenital anomalies simply as anatomic defects that are present at birth.
But as you pointed out earlier, congenital does not automatically mean genetic.
Not at all. Some cardiac or renal defects might be present at birth, but, they only lead to clinical symptoms or get diagnosed years and years later.
And the prevalence is significant. I mean, we are talking about 1 in 33 babies. That's roughly 120,000 infants annually in the U.S. born with a recognizable birth defect.
And we have to remember that number only reflects live births. The sources estimate that maybe 20% of all fertilized ova contain such severe anomalies that they result in spontaneous abortion.
Often before the pregnancy is even clinically confirmed.
Exactly. The developmental screening process is brutal, and it's mostly invisible to us.
So for the anomalies that do make it to term, we rely on a pretty precise classification system to understand how the defect arose, right? Was the initial blueprint flawed? Or was a previously perfect structure somehow damaged along the way?
That's the core distinction. It hinges on distinguishing between three distinct categories: malformations, disruptions, and deformations. The difference is the source of the error. Is it intrinsic versus extrinsic?
Okay, so let's start with malformations.
Malformations are primary errors of morphogenesis. They happen because the underlying developmental process itself was intrinsically abnormal right from the get-go.
Think of it as a flaw in the original architectural blueprint.
Perfect analogy. And these are usually multifactorial, or they're caused by chromosomal or single-gene defects.
So we see this in conditions like polydactyly with extra digits or syndactyly where digits are fused.
Right. And while some malformations are benign, others are devastating. The source mentions severe ones like cyclopia, which is a failure of midface cleavage.
Which is often associated with holoprosencephaly.
It is. And this is essentially a failure in the fundamental crafting of the brain and face. Defects of this severity are usually lethal.
So that's an intrinsic failure. How does that contrast with a disruption?
With a disruption, the development process was initially normal. Everything was going according to plan. But then a secondary extrinsic factor came along and destroyed or damaged a previously formed organ or body region.
The classic and visually striking example the source provides is amniotic bands.
It's a perfect example. Imagine the amnion, the membrane surrounding the fetus. It ruptures early in pregnancy.
And it forms these tough, fibrous strings that are just floating in the amniotic fluid.
And these bands can wrap around a limb, a finger, any developing structure, really. And they compress it or can even cause amputation. The resulting defect isn't heritable. It's a secondary injury.
Okay, and the third category is deformations.
Deformations. Like disruptions, these are extrinsic, but they're caused by abnormal biomechanical forces that physically mold a structure into an abnormal shape. The underlying tissue is fine, but it was just squeezed.
So the most common root cause is mechanical uterine constraint.
Exactly. As the fetus is going through its rapid growth phase, its size can outpace the uterine capacity. You couple this with oligohydramnios, too little amniotic fluid acts as a cushion, or multiple fetuses in there.
And the fetus just gets compressed.
It gets compressed. A common result is club feet, where that persistent compression of the foot in an abnormal position leads to permanent structural changes.
And this distinction must be crucial for genetic counseling.
Oh, absolutely. If you can tell the parents the defect is a non-heritable disruption, like from amniotic bands or deformation from compression, you can reassure them about the risk in future pregnancies.
This leads us right into the concepts of sequences and syndromes, which describe how multiple defects can be linked together.
Right. A sequence is a simple chain reaction. A single initial anomaly triggers a cascade of subsequent related anomalies.
The oligohydramnios, or Potter sequence, is the classic example here.
It's the archetypal example. It begins with one single problem: severely decreased amniotic fluid, or oligohydramnios. And why is that fluid gone? Well, maybe the fetal kidneys didn't develop renalogenesis, which means no fetal urine.
And fetal urine is the main source of amniotic fluid later in pregnancy.
Correct. So that single initiating event, the oligohydramnios, leads directly to fetal compression.
And that compression causes multiple predictable secondary problems.
Things like flattened facies, so squashed features, positional abnormalities of the hands and feet, like club feet, and most critically, that prolonged compression of the chest wall physically inhibits lung growth,
leading to what's often fatal pulmonary hypoplasia.
and the devastating domino effect that starts from just one localized failure.
Okay, so how is that different from a malformation syndrome?
In contrast, a syndrome is a group of anomalies that are pathologically related, but they are not the result of a chain reaction.
But it's not a domino effect.
No. Instead, a single etiologic agent, say, a specific chromosomal abnormality like trisomy 21, Down syndrome, or a maternal viral infection, simultaneously disrupts multiple different tissues at the same time during their development.
When we look at the causes behind all these anomalies, the breakdown in the source material is, well, it's sobering, we have to be honest. 40% to 60% of cases are still categorized as unknown.
We just don't have the answer yet.
We don't. But for the known causes, that's where we gain leverage. Genetic factors account for what, 12 to 25%?
That's right. And that encompasses chromosomal aberrations and single-gene Mendelian disorders. For instance, the source mentions how severe midbrain defects like holoprosencephaly can be linked to mutations in the head-hug signaling pathway.
Which shows the molecular root of that malformation.
Precisely.
Then we have environmental causes, around 8 to 11%. This includes maternal infections, which we group together as TORS each. Wait, Let's pause here. The acronym is toxoplasmosis, others, rubella, cytomegalovirus, and herpes virus. But why are they grouped together clinically?
That's a fantastic question. They're grouped because they all share the ability to cross the placenta and infect the fetus in utero.
Okay.
But more importantly, they cause very similar clinical syndromes in the infant. Things like microcephaly, hydrocephalus, chorioretinitis, intellectual disability, cataracts, cardiac anomalies. They represent a similar pattern of systemic disruption early in gestation.
And it's important to acknowledge that rubella embryopathy, which was once a major cause, has been virtually eliminated in high-income countries.
Which just proves the power of vaccination. It's a huge public health win.
We also can't overlook maternal disease states. Take diabetes mellitus.
Right. Despite modern insulin therapy, the sources note that infants of diabetic mothers still face a 6% to 10% incidence of major malformation.
And the mechanism there involves maternal hyperglycemia leading to fetal hyperinsulinemia.
Which results in fetal macrosomia, so an abnormally large baby, and these severe cardiac and central nervous system defects.
And then, of course, the infamous teratogens, the drugs and chemicals.
The historical tragedy of thalidomide, which caused those limb reduction defects, really taught us a painful lesson about the critical timing of drug exposure.
And today we know alcohol causes fetal alcohol syndrome growth restriction, facial anomalies, severe psychomotor disturbances, and retinoic acid, used for severe acne, is also a recognized teratogen,
causing CNS, cardiac, and craniofacial defects.
And this is where the environment and genetics truly intersect, in the multifactorial category. That's 20 to 25% of anomalies.
Right. These are polygenic defects that are subtly influenced by environmental triggers. Think of things like cleft lip lead or neural tube defects.
And this brings us to that crucial aha moment in the source material, the folic acid story.
Yes. Neural tube defects, or NTDs, are multifactorial. Yet the simple public health measure of advising periconceptional intake of folic acid dramatically reduced the incidence.
It's proof that you don't necessarily have to eliminate the underlying contributing genes. Sometimes, just adjusting the environmental stimulus, in this case, providing sufficient folate, can prevent the complex developmental failure.
It's a major victory in public health and a model for intervention.
And that success hinges entirely on understanding the timing of the insult. The diagram in the source, figure 10.5, illustrates this concept of susceptibility beautifully.
It does. Prenatal development is divided into the early embryonic period, which is the first 9 weeks, and then the fetal period.
And the critical period for structural malformation is weeks 3 through 9. That's when organogenesis is in full swing.
And the embryo is extremely susceptible to teratogenesis, with the peak sensitivity falling shockingly early, often between the 4th and 5th weeks of gestation.
Which is often before a woman even knows she's pregnant.
Exactly. If a damaging insult occurs during that critical window, you get major morphological abnormalities. If the insult happens earlier, in the first 3 weeks, it often results in either the death of the embryo or, a full recovery with no defect.
And if it happens later in the fetal period, from 9 weeks onward,
then it generally causes growth restriction or damage to already formed organs, like the brain, testes, or teeth, but typically not those major structural malformations.
This is where it gets really interesting, connecting back to the genetic pathways. The sources provide examples where chemical teratogens essentially act as functional mimics of genetic defects.
They do. For example, the plant toxin cyclopamine causes craniofacial abnormalities by inhibiting hedgehog signaling. And we know that genetic mutations in the hedgehog pathway cause the exact same defects.
Or take the anti-epileptic drug valproic acid, which disrupts HOX proteins.
And HOX proteins are master regulators of patterning in the developing embryo. So mutations in HOX genes cause congenital anomalies that functionally resemble valproic acid embryopathy.
It just demonstrates that the developmental pathway is the target, right? It doesn't matter if the interruption is genetic or chemical.
That's the key takeaway.
Okay, let's transition now from errors in the blueprint to the immediate challenges of early survival. We're focusing on the perinatal period, which is dominated by 2 concepts, prematurity and fetal growth restriction.
And prematurity, defined as less than 37 weeks gestation, is the second leading cause of neonatal mortality.
It affects nearly 1 in 10 U.S. infants, and again, those disparities are striking. 14% incidence among African-American women versus 9% in white women.
And we can identify several key risk factors, like preterm premature rupture of membranes, or PP-PROM, uterine or cervical abnormalities, and multiple gestation.
But the source material places a really strong emphasis on intrauterine infection. That's present in about a quarter of all preterm births.
Right. And we're talking about often overlooked microbes like ureaplasma and mycoplasma. And we understand the molecular connection now.
How does that work?
The current thinking suggests that the body's recognition of these bacterial components via things called toll-like receptors or TLRs triggers the production of prostaglandins.
And prostaglandins are potent stimulators of uterine contractions.
Exactly. They initiate labor prematurely. It's an inflammatory cascade that mistakenly triggers birth.
Now, we have to clearly define fetal growth restriction, or FGR. These are the small for gestational age infants.
This is a crucial distinction, because a baby can be premature but still be the appropriate weight for their age. FGR means the infant is genuinely undergrown for the time they were in utero.
And what causes that?
FGR is most often caused by maternal issues that reduce placental blood flow, things like preeclampsia, chronic hypertension, smoking, or poor nutrition. And we divide FGR into two types based on the cause.
Okay.
Fetal factors, like chromosomal disorders or Tourette infections, tend to cause symmetric FGR. That means all organ systems, including the brain, are proportionally small.
But the most fascinating mechanism is asymmetric FGR. That's typically caused by placental insufficiency.
And physiologically, this is an incredible act of fetal survival.
Yeah.
The body detects that decreased nutrient flow and enacts a brain-sparing mechanism.
So it's protecting the most important organ.
Precisely. The fetal circulation prioritizes blood flow to the brain at the expense of the liver, muscle, and subcutaneous fat. The result is a baby who is disproportionately small, often appearing long and thin with a relatively large head.
So the brain is spared from the growth restriction.
It is, but the sources note that SGA infants, regardless of the FGR type, still face a higher long-term risk of cerebral dysfunction and learning disabilities compared to appropriate weight infants.
Moving on, the immediate peril for the premature infant is neonatal respiratory distress syndrome, or RDS, also known as hyaline membrane disease.
And the statistics are horrifyingly inverse to gestational age, a 93% incidence in infants born at 28 weeks or less.
The pathogenesis is the single most important concept here.
It really is. The fundamental defect is pulmonary immaturity and surfactant deficiency. Surfactant dipalmitoyl phosphatidylcholine is a substance that reduces the surface tension inside the alveoli.
I always think of it like this, trying to inflate a deflated balloon. If the rubber is sticky, it takes a ton of force to get it open.
That's a perfect analogy. Surfactant acts like a nonstick coating. Without it, the surface tension is so high that the tiny, delicate alveoli collapse completely, a condition called atelectasis, with every single breath.
With every single breath.
The infant has to work tremendously hard simply to breathe. This leads rapidly to exhaustion, hypoventilation, hypoxemia, and acidosis.
And that acidosis then causes the small pulmonary arteries to constrict.
Vasoconstriction, leading to hypoperfusion. And this lack of blood flow, coupled with the oxygen deprivation, damages the delicate alveolar lining cells.
And that damage is what allows plasma proteins rich in fibrin to leak into the air spaces.
Right. And this protein-rich exudate mixes with necrotic cellular debris from the damaged lung cells. That mixture is what forms the diagnostic, thick, glassy layer known as the hyaline membranes.
It's a vicious, self-perpetuating cycle of collapse and injury.
It is. And we have to remember the modulators of risk, too. High levels of cortisol from intrauterine stress can actually accelerate lung maturation and decrease the risk of RDS.
But on the other hand, high insulin levels, common in infants of diabetic mothers, suppress surfactant synthesis,
which significantly increases the risk. Also, a C-section before labor increases the risk because the stress of labor itself triggers beneficial hormone releases that boost surfactant production.
So let's turn to the visual pathology. If we look at the gross appearance of the lungs, they are a striking sight.
They are. They're solid, airless, and deep reddish purple. The source describes them as having the consistency and color of liver. And crucially, they sink in water because they lack the entrapped air needed for buoyancy.
And microscopically, the H&E slide must be unmistakable.
It is. You see the collapsed, poorly developed alveoli. And lining the respiratory bronchioles and alveolar ducts is that characteristic thick pink eosinophilic layer, the hyaline membrane, which is primarily made of fibrin.
And a key pathological detail is the remarkable paucity of neutrophilic inflammation around these membranes.
That's right, and that confirms that the injury is primarily hypoxic and circulatory, not infectious.
Thankfully, advances in prevention, antenatal steroids, and prophylactic exogenous surfactant have drastically improved prognosis. But survival introduces new complications.
It does. One major long-term issue is retinopathy of prematurity. The source details this fascinating two-phase pathogenesis.
Okay, what's phase 1?
Phase 1. High oxygen therapy, which is necessary for survival, paradoxically causes the shutdown of retinal vessels and decreases vascular endothelial growth factor, or VEGF.
Right.
This causes the existing vessels to shrink or die.
And then phase 2 is when the infant returns to room air.
Exactly. The retina is now relatively hypoxic, which leads to a massive uncontrolled surge in VEGF. This induces chaotic, aggressive growth of new retinal vessels, neovascularization, which can pull on the retina, causing detachment and blindness.
So it's a terrible consequence of life-saving oxygen therapy.
It is. And in the lung itself, we often see bronchopulmonary dysplasia, which is characterized by the arrest of pulmonary development at the saccular stage.
So instead of forming that delicate, complex network of mature alveoli,
The lung ends up with simplified, large alveolar structures, which permanently impairs gas exchange capability.
let's address a devastating gastrointestinal issue next. Necrotizing enterocolitis, or NEC.
This is a life-threatening inflammatory disease of the bowel. It occurs most commonly in premature infants, with the incidence being inversely proportional to gestational age.
And the pathogenesis is multifactorial, but it centers around prematurity, feeding, and bacterial overgrowth.
Right. The source highlights the role of platelet activating factor, or PAF. Increased PAF levels promote apoptosis programmed cell death in the enterocytes, and this compromises the tight junctions between the cells.
So that loss of integrity makes the mucosal lining permeable.
And then gut bacteria migrate through the damaged wall, causing a massive inflammatory and necrotic response, which can lead to sepsis and shock.
Clinically, the infant presents with bloody stools, severe abdominal distension.
And the key diagnostic sign on radiographs, pneumatosis intestinalis. That's gas trapped within the wall of the intestine itself.
If we look at the morphology of NEC, the gross findings typically involve the terminal ileum, cecum, or right colon.
And that segment is distended, friable, congested, and potentially gangrenous. Microscopic examination is definitive. You see coagulated necrosis, ulceration of the mucosa, bacterial colonization.
And those unmistakable submucosal gas bubbles, the pneumatosis intestinalis.
That's the one. That confirms the presence of air released by bacteria or leakage into the bowel wall.
Finally, for this section, let's briefly review perinatal infections. They threaten the infant through two main routes. The first is transcervical, or ascending.
That's acquired in utero or during birth. It's typically bacterial agents like group B streptococcus, and it leads to pneumonia, sepsis, or meningitis.
And the second is transplacental, or hematologic.
Right. Here, the pathogens, viruses, parasites, some bacteria like Listeria trochilionic villi. The clinical picture varies widely based on the gestational age at the time of infection.
There's a fascinating example, parvovirus B19.
Yes. While it's relatively benign in older children, it causes fifth disease in the fetus. It has a specific tropism for erythroid precursors.
So it targets the cells that make red blood cells.
It destroys them. It leads to isolated pure red cell aplasia and severe anemia, which often results in hydrops fetalis. The diagnostic clue on the bone marrow slide is the presence of these large, homogeneous intranuclear inclusions in the remaining erythroid precursors.
And the entire TOR-RCH group is studied together because, regardless of the agent, they all produce that similar constellation of chronic clinical sequelae.
Exactly, affecting brain development, vision, and the heart.
All right, let's move on to fetal hydrops, defined as a generalized accumulation of edema in the fetus.
It signifies a profound systemic failure and is often lethal. It can range from localized fluid pockets, like pleural effusions, to massive total body swelling, or anasarca.
And historically, the cause was overwhelmingly immune hydrops.
Right, rooted in Rh blood group incompatibility. The story of how medicine tackled this is one of our greatest immunological success stories.
Let's break down the mechanism of immune hydrops. It requires an Rh-negative mother to be exposed and sensitized to Rh-positive red cells from her fetus.
Which usually happens during a previous birth or some sort of placental trauma. That sensitization causes the mother to produce IgG antibodies.
And because IgG is a small molecule, it freely crosses the placenta.
So in a subsequent pregnancy with an Rh-positive fetus, those maternal antibodies cross over, attach to the fetal red cells, and trigger a massive hemolytic reaction, the destruction of those red cells.
And the crucial part of the story is prevention. administering RA, or rhesus immune globulin, to Rh-negative mothers immediately after delivery.
It essentially blocks the mother's immune system from ever seeing the fetal Rh antigens and prevents that sensitization from happening in the first place.
So why is ABO incompatibility so much more common, but typically mild?
Great question. It's because most anti-A or anti-B antibodies are large IgM molecules, which do not cross the placenta easily. And on top of that, fetal red cells express those AB antigens very weakly.
So the consequence of that severe red cell destruction in immune hydrops is twofold. First, profound anemia.
Right. This anemia causes hypoxic injury, particularly to the heart, leading to cardiac failure, and to the liver, which impairs plasma protein synthesis.
And low plasma protein means low oncotic pressure, so fluid leaks out of the vessels and into the tissues, causing the hydrops.
And second, the rapid breakdown of hemoglobin generates massive amounts of unconjugated bilirubin, which leads to severe jaundice.
So because of the widespread success of Rh prophylaxis, non-immune hydrops is now the dominant form.
It is. And here, the hydrops is not caused by antibodies, but by other systemic issues. The major causes are severe cardiovascular defects, chromosomal anomalies like Turner syndrome or trisomies 21 and 18.
And non-antibody-mediated fetal anemia, like from homozygous alpha thalassemia or that parvovirus B19 infection we just talked about.
Correct.
The morphology of the hydroptic fetus is very distinct. Grossly, the generalized fluid accumulation, the anasarca, is obvious.
And the source notes that specific localized findings, particularly cystic hygroma, these are fluid collections in the neck, soft tissues, are highly suggestive of underlying chromosomal anomalies like 45X or Turner syndrome.
And due to that catastrophic anemia, the fetal body mounts a desperate compensatory response.
You see massive hyperplasia of the bone marrow and extensive extramedullary hematopoiesis, new blood cell formation in tissues like the liver and spleen, which aren't normally major blood cell factories at that stage.
So if we visualize that pathology in the liver, the H&E slide would show the mature hepatocytes just scattered with these numerous islands of small, dark blue cells.
Those are the immature hematopoietic cells, the red cell precursors, trying to compensate for the loss. This overwhelming presence of immature red cells in the circulation gives us the descriptive name erythroblastosis fetalis.
But the most serious and enduring threat of severe hemolysis is the resulting neurological damage known as kernicterus.
Yes, the unconjugated bilirubin, which is highly fat-soluble, easily crosses the poorly developed blood-brain barrier in the neonate.
And this toxic bilirubin binds irreversibly to lipids in the brain tissue, causing widespread damage, particularly to the basal ganglia, the thalamus, and the cerebellum.
The visual evidence when you section the brain is dramatic. Bright, intense yellow discoloration in these deep brain structures.
And this is why aggressive management of neonatal jaundice is paramount.
Absolutely. Phototherapy works by using light to change the unconjugated bilirubin into harmless, water-soluble products that the baby can excrete. And if phototherapy fails, exchange transfusion is necessary to literally flush the toxic antibodies and bilirubin out of the baby's circulation and prevent permanent neurological injury.
Our deep dive shifts now to inherited disorders, the inborn errors of metabolism. These are genetic defects, usually autosomal recessive, that lead to a block in a crucial metabolic pathway.
And that causes either the accumulation of a toxic substrate or the deficiency of an essential product.
Clinically, these can be cryptic. Sometimes presenting with the bizarre-like abnormal body or urine odor, or more general signs like seizures or failure to thrive.
Right. But we're going to focus on two conditions where newborn screening is utterly transformative because early intervention prevents tragedy.
First, phenylketonuria, or PKU.
This is an autosomal recessive disorder caused by a severe deficiency of the enzyme phenylalanine hydroxylase, or PAH.
And PAH is the chemical bottleneck that converts the amino acid phenylalanine into tyrosine.
So without functional PAH, phenylalanine accumulates at toxic levels. Untreated infants appear normal at birth, but by 6 months, they develop severe intellectual disability, microcephaly, and seizures.
They also have a characteristic musty or mousy body odor and reduced pigmentation.
Because tyrosine is a precursor for melanin.
Right. And the genius of early screening is that we can detect that high phenylalanine level and immediately restrict it through a specialized diet.
It's a simple intervention that prevents the buildup of the toxic metabolite and allows for almost normal cognitive development.
However, the source material introduces the concept of maternal PKU, which is profoundly important.
It is. If a woman who was successfully treated for PKU in childhood discontinues her strict diet in adulthood, Her own high phenylalanine levels will expose her developing fetus to teratogenic effects.
Even if the fetus is only a carrier for PKU.
Even if the fetus is just heterozygous, that exposure causes devastating effects. Intellectual disability, microcephaly, congenital heart disease. It means the mother must resume and strictly adhere to that restricted diet before conception and throughout the entire pregnancy.
So the successful treatment of one generation introduces a new critical challenge for the next.
Exactly.
The second screening priority is galactosemia.
This is caused by an autosomal recessive deficiency of galactose-1-phosphate uridyl transferase, or GALT. The result is the accumulation of galactose-1-phosphate and its toxic byproducts in various tissues.
And this accumulation yields a striking clinical triad.
It does. First, failure to thrive and liver toxicity, leading to a cirrhosis that pathologically resembles the damage from alcohol abuse. Second, cataracts. Galactitol accumulates in the lens, creating an osmotic gradient that makes the lens swell and opacify.
And third, there's a significantly increased risk of fulminant E. coli septicemia in the first few weeks of life.
And just like PKU, the intervention is dietary. Early diagnosis allows for the removal of galactose from the diet, usually by switching to soy-based formulas. This prevents the liver damage and cataracts, though patients may still experience lead effects like speech disorders and gonadal failure.
These two examples powerfully illustrate the concept of successful preventive pediatric pathology.
They really do.
Now, we dive into the most common lethal genetic disease in Caucasians, cystic fibrosis, or CF.
It affects 1 in 2,500 live births, and it's fundamentally an inherited disorder of ion transport, which leads to abnormally thick, viscous secretions that obstruct multiple organ passages throughout the body.
The defect is in the cystic fibrosis transmembrane conductance regulator CFTR gene on chromosome 7.
And the CFTR protein itself is this complex structure that acts as an anion channel, primarily conducting chloride and bicarbonate ions. A malfunction in the single massive protein underlies the entire disease.
The reason this disease is so devastating and complex is the tissue-specific function of that CFTR channel.
Wait, let's slow down here. This is where it gets counterintuitive. How does the same faulty protein cause two totally opposite effects? Salty sweat outside the body and dehydrated mucus inside the body.
That is the essential physiological paradox of CF. So let's look at the sweat duct first. The normal function of CFTR here is reabsorption. It pulls chloride ions out of the sweat as it passes through the duct, and that helps pull sodium out too.
Okay.
When CFTR is defective, you lose that reabsorption. So the sweat remains hypertonic or abnormally salty. This is why the sweat test, measuring that high sodium chloride concentration, is the classic diagnostic tool.
Right. Now, what about the airway and the intestine?
The job here is secretion, the opposite of the sweat duct. Normal CFTR secretes chloride ions into the lumen, and crucially, normal CFTR also inhibits the epithelial sodium channel, or ENS.
So when CFTR is defective in the airway, you lose two things. You lose chloride secretion, and you lose the inhibition on ENAC. So ENAC runs rampant, causing an excessive rate of sodium and water reabsorption out of the lumen and back into the tissue.
So the surface fluid layer, the layer that cleans the airways, becomes isotonic but drastically low volume. It gets dehydrated.
Exactly. This dehydrated fluid layer means the mucociliary action is defective, the mucus becomes thick, obstructive, and sticky, and the patient is primed for chronic recurrent infection.
And we also have to acknowledge the role of bicarbonate transport.
We do. Mutant CFTR severely impairs bicarbonate conductance, leading to highly acidic secretions. And this acidity promotes mucin precipitation and duct plugging, which is the direct link to the catastrophic damage we see in the pancreas.
The disease is driven by incredible molecular heterogeneity, with mutations grouped into 6 classes based on how they damage the protein.
Right. We can summarize the impact. Classes 1 and 2 are the most severe. Class I means no protein synthesis at all. Class 2, which includes the most common mutation, Phe508 means the protein is synthesized, but it's misfolded and degraded before it ever reaches the cell surface.
So those are the severe mutations.
They are. Class 3 means defective regulation. The protein's on the surface, but the gate is locked shut. So classes I through 3 result in classic CF, severe pulmonary disease, and pancreatic insufficiency.
And classes 4 through 6 are mild mutations.
Correct. For example, class 4 means decreased conductance, and class V means reduced abundance. If a patient has even one mild mutation, that small amount of residual CFTR activity can be enough to prevent pancreatic duct plugging, leading to a less severe phenotype.
And this molecular spectrum explains why some patients have atypical CF.
Exactly. They have the biallelic CFTR mutations, but they present only with isolated features like late-onset COPD, idiopathic chronic pancreatitis, or, most commonly in males, isolated obstructive azoospermia due to congenital absence of the vasa deferens.
Turning to the pulmonary pathology, which is the major cause of morbidity and mortality, the morphology shows the lungs filled with extremely viscous mucus,
Leading to chronic obstruction, chronic bronchitis, and severe bronchiectasis. That's permanent, irreversible widening of the airways. The infected, consolidated parenchyma can literally appear green due to the bacterial pigments.
And the microbiology is aggressive. Pseudomonas aeruginosa colonizes 80% of patients by age 20.
And it often adopts a mucoid alginate-producing form that creates a protective biofilm, making it virtually impervious to both antibiotics and the host's immune defenses,
The sources also mention the highly virulent Burkholderia cepacia complex.
which can cause the fulminant cepacia syndrome.
And the non-pulmonary issues are extensive. 85 to 90% suffer from pancreatic insufficiency.
Due to duct plugging, atrophy, and replacement of the parenchyma with fibrous tissue and fat. This leads to severe malabsorption and vitamin deficiencies. And early on, 5 to 10% of neonates present with meconium ileus, a serious intestinal obstruction.
And as patients live longer, liver disease becomes a major concern.
It does. Bile canaliculi plug up, leading to focal biliary cirrhosis in about a third of patients, which can progress to diffuse cirrhosis in a small but significant percentage, becoming a major cause of late-stage death.
But the therapeutic advances here are revolutionary, and they're driven entirely by this molecular pathology.
Absolutely. Instead of just treating the symptoms, we now target the specific molecular defect based on those 6 classes.
We have potentiators for class 3 mutations that keep the channel bait open. We have correctors for class 2, like the common AF508, that assist the misfolded protein in reaching the cell surface.
And amplifiers for class V that increase the amount of normal protein produced.
So the combination therapy, a potentiator plus a corrector that's approved for patients who are homozygous for AF508, has redefined the disease.
It has. This targeted precision medicine approach, derived directly from understanding the molecular pathology, has successfully extended the median life expectancy for patients with CF to 50 years. It's one of the most compelling narratives in modern genetic medicine.
We must now turn to sudden infant death syndrome, or SIDS, which is a devastating diagnosis. It requires absolute definitional clarity because it is fundamentally a diagnosis of exclusion.
Right. SIDS is the sudden death of an infant under 1 year of age that remains unexplained after a thorough case investigation. And that means a complete autopsy, a detailed death scene examination, and a full review of the clinical history.
And this is a critical distinction because the broader category is sudden unexpected infant death, or SUID.
And many SUID cases do reveal an unexpected identifiable cause at autopsy, maybe a viral myocarditis, an unsuspected congenital cardiac defect, or a metabolic disorder like a fatty acid oxidation disorder.
And those are not SIDs.
They are not cystides. SIDs accounts for roughly half of all SUID cases.
Epidemiologically, SIDS remains the leading cause of death between 1 month and 1 year. And the statistics show this very tight window of vulnerability.
They do. 90% of SIDS deaths occur between 2 and 4 months of age.
We noted the massive success of the Back to Sleep, Now Safe to Sleep campaign that was initiated in the 1990s. Mortality rates plummeted.
They did. Yet, as with prematurity and mortality overall, the same severe racial disparities persist. Rates are more than double in non-Hispanic, Black, and American Indian Alaskan Native infants compared to white infants.
Which again points to those structural vulnerabilities related to socioeconomic status, education, and access to resources.
Absolutely.
The prevailing theory for the underlying mechanism is the triple risk model. It posits that SIDs requires the co-occurrence of 3 factors, and the death only happens when all 3 overlap.
Okay, so first, you need a vulnerable infant. These are the intrinsic factors. The most compelling hypothesis centers on the delayed development of arousal and cardiorespiratory control.
And this vulnerability is hypothesized to be linked to dysfunction in the serotonergic, or 5-HT system in the medulla oblongata.
In the brainstem. And that area is so important because it controls the body's involuntary protective mechanisms, including the ability to awaken or shift position in response to noxious stimuli like hypoxia-low oxygen or high carbon dioxide during sleep.
So if an infant has this impaired arousal response, they essentially fail to detect that they are suffocating or rebreathing carbon dioxide, and they just don't wake up.
That's the theory. And supporting factors for vulnerability include prematurity, low birth weight, and notably maternal smoking during pregnancy, which can double the risk.
There's a genetic component, too. Inherited metabolic defects like MCAD deficiency can account for up to 5% of SUIs.
Right, so that's factor one. Second, you need the critical developmental period, that 2 to 4 month peak. This is when rapid changes are occurring in the infant's autonomic and respiratory control systems, making them transiently unstable.
And third, you need an exogenous stressor. This is the environmental trigger.
And these are the modifiable risks. Prone or stomach sleeping, sleeping on an overly soft surface like a plush mattress, or with loose bedding, co-sleeping in the first 3 months, and thermal stress or overheating.
The Back to Sleep campaign was so successful because it directly addressed these exogenous factors.
It did.
So given that SIDS is defined by what is not found, what does a SIDS autopsy reveal? Pathologists must meticulously rule out all other causes.
The findings are subtle and nonspecific. The most common finding, present in 80% of cases, are tiny hemorrhages, called petechiae, scattered across the thymus, pleura, and epicardium.
And these are possibly due to increased negative pressure in the chest before death?
Possibly. The lungs also appear congested and edematous, but the more subtle, long-term findings are in the brainstem.
What do you see there?
Microscopic analysis can reveal astrogliosis, which is a type of scarring in the brainstem and cerebellum, or sometimes hypoplasia or underdevelopment of the arcuate nucleus.
And these subtle CNS abnormalities are interpreted as possible signs of chronic hypoxemia or delayed development in those critical arousal centers.
Which fits perfectly with the triple risk model's vulnerable infant concept. It's only when these subtle signs are found and all other specific causes are ruled out that the final, difficult diagnosis of SIDs can be rendered.
We conclude our deep dive by focusing on tumors, which present a unique challenge in childhood. While only 2% of all malignant tumors occur in this population, cancer remains the second leading cause of death after accidents in that crucial 5 to 14 age group.
And the most important distinguishing feature from adult oncology is the cell of origin. Adult cancers are overwhelmingly epithelial carcinomas. In contrast, common childhood tumors are primarily of mesenchymal derivation.
Meaning they arise from soft tissue, bone, kidney, or nervous tissue.
Exactly. And before diving into true malignancies, we have to distinguish two common non-neoplastic lesions that are often confused with tumors. First, heterotopia or choristoma.
And this is defined as microscopically normal cells or tissues growing in an abnormal location.
Think of it like this, having perfectly normal bricks, but they're built into the wrong house. For example, a small mass of pancreatic tissue found embedded in the stomach wall.
Or adrenal cortical cells found in the kidney.
Right. They're usually benign, but can confuse surgeons and pathologists.
And the second one is hamartoma.
A hamartoma is an excessive focal overgrowth of cells that are native to the organ, but the cells are disorganized and they lack the normal architectural arrangement.
So things like hemangiomas or rhabdomyomas of the heart are often classified here.
They are. And the line between a hamartoma and a truly benign clonal tumor is often quite blurry.
When looking at benign tumors, hemangiomas are the most common tumor of infancy, often appearing on the face or scalp.
And what makes them unique is their natural history. Many of them spontaneously regress by age 5 to 7, which requires careful observation rather than immediate aggressive intervention.
In fibrous tumors, the source notes the fascinating case of congenital infantile fibrosarcomas.
Yes. These tumors can look histologically aggressive and malignant, but they carry an excellent prognosis. The key to their favorable outcome is often a specific chromosomal abnormality, the translocation T1215.
Which results in the ETV6 and TRK3 fusion transcript.
And that specific molecular signature dictates the treatment and the prognosis.
We also have teratomas, which show two incidence peaks, early childhood and late adolescence.
They arise from tutipotent germ cells and contain tissues derived from all three germ layers. So you might see skin, bone, gut tissue, all in one tumor. The most common site is the sacrococcygeal region.
And their malignant potential correlates directly with the amount of immature neural epithelial tissue present within the tumor.
Correct.
Now, onto the serious malignancies. They share a characteristic primitive, undifferentiated appearance, often classified as small, round, blue cell tumors.
That's due to their microscopic look sheets of small cells with dark, round nuclei and very little cytoplasm. And they frequently carry the suffix blastoma, which signifies their primitive nature.
Let's begin with neuroblastic tumors. Neuroblastoma is the most common extracranial solid tumor of childhood, with a median age of 18 months.
40% arise in the adrenal medulla. with the remainder along the sympathetic chain. Clinically, they often present as a large abdominal mass, and pathologists look for elevated urine levels of catecholamine metabolites, specifically VMA and HVA, which are key diagnostic markers.
Because these tumors produce catecholamines.
They do. Grossly, the tumor is soft, gray tan, often showing areas of necrosis and hemorrhage. Microscopically, we see dense sheets of those small primitive cells. The definitive diagnostic feature for the pathologist is the Homer-Wright pseudoreset,
Where the tumor cells are concentrically arranged around a central core space filled with this fibrillary material called neuropil.
the primitive nerve fibers. And an interesting aspect is that these tumors can show maturation. They can differentiate into a ganglioneuroblastoma, which is a mixed tumor, or a fully mature benign ganglioneuroma.
Characterized by large mature ganglion cells and an abundant Schwann cell stroma.
And the presence of that mature stroma is generally associated with a much more favorable prognosis.
The prognosis for neuroblastoma is extremely complex, though, and highly stage and age-dependent.
It is. There is a critical dichotomy at 18 months of age. Infants under 18 months have a significantly more favorable outcome, often even with metastatic disease.
There's even a unique entity called stage 4S, which is applicable only to infants under 1 year.
Right. The primary tumor is localized, but there is limited metastasis to the skin, sometimes presenting as the blueberry muffin baby, the liver, or the bone marrow. And these 4S tumors often spontaneously regress without aggressive treatment.
Which is just astonishing.
It is. However, the single most important prognostic determinant is genetic. MYCN amplification. This proto-oncogene is amplified in 20% to 30% of tumors.
So if you see MYCN amplification, that changes everything.
It overrides all other favorable factors, including age and stage. The source material provides a stark example. In one study cohort, the survival rate plummeted from 93% to a mere 10%, solely based on the presence of MYCN amplification.
Wow. So this molecular marker bumps any tumor into the high-risk category, mandating aggressive, high-intensity therapy.
It does. And there are other complex genetic features, too, like the aggressive near-diploid tumors, which often show segmented chromosomal aberrations, including this complicated, massive chromosomal fragmentation known as chromothripsis.
Literally chromosome shattering.
In a single event, resulting in highly unstable genomes.
Finally, we turn to Wilms tumor, or nephroblastoma. This is the most common primary renal tumor of childhood, peaking between ages 2 and 5.
And this is a massive success story in oncology. The cure rates have soared from 30% to nearly 90% today.
Its pathogenesis is a textbook example of the link between malformation and neoplasia.
It is. It's strongly associated with several genetic syndromes, all linked to the 11p locus. The most famous is Wad-Yor syndrome Wilms tumor, aniridia, genitourinary anomalies, and intellectual disability caused by a deletion on 11p13 involving the WT1 gene.
Then there is Dinistrash syndrome,
Caused by a dominant negative missense mutation in WT1, which confers an extremely high lifetime risk of developing Wilms tumor, around 90%, coupled with gonadal dysgenesis and early onset renal failure.
and Beckwith-Wiedemann syndrome, or BWS.
That's linked to an imprinting abnormality at 11p15.5. This syndrome is characterized by overgrowth features, macroglossia, organomegaly, and an increased tumor risk. The mechanism involves the loss of normal genetic silencing, leading to the overexpression of the embryonal growth factor, IGF-2.
And this excess growth factor drives the development of Wilms tumor.
Correct.
Grossly, Wilms tumor is a large, solitary, and typically well-circumscribed mass. Microscopically, it attempts to mimic developing kidney tissue, exhibiting the classic triphasic pattern.
This triphasic pattern contains 3 elements. 1, the small, dark blastomal component, which are the primitive cells. 2, the epithelial component, forming abortive tubules and glomeruli. And 3, the stromal component, which is fibroblastic or skeletal muscle tissue.
And while the cure rate is high, the prognosis hinges on one microscopic feature, anaplasia.
It does. Anaplasia is defined by large, dramatically enlarged hyperchromatic nuclei, increased pleomorphism, and abnormal mitosis. The presence of diffuse anaplasia correlates with TP53 mutations and critically resistance to chemotherapy.
So that feature is the most critical determinant of an adverse prognosis.
It is. And finally, we have to note the precursor lesions, nephrogenic rests. These are persistent foci of primitive kidney cells found adjacent to 25 to 40% of unilateral Wilms tumors.
And they are present in 100% of bilateral tumors.
Which necessitates long-term surveillance because they signal a high risk of developing a tumor in the contralateral kidney.
So what does this all mean? Our journey today, from defining the intrinsic defects of malformation and the high stakes of prematurity, to understanding the single protein failure of cystic fibrosis and the molecular markers driving pediatric cancers, it really shows the incredible depth of knowledge pathology has achieved in this field.
I agree. We are moving beyond just treating symptoms to intercepting failure at the molecular level.
The progress is immense. I mean, the success in extending the life of a CF patient to 50 years, the near elimination of rubella embryopathy, and the near 90% cure rate for Wilms tumor are powerful demonstrations of how understanding the why, the specific mechanisms, genetic or environmental, translates into successful interventions and dramatically improves survival. But with that success comes a challenging and long-term cost, and that's the final provocative thought for you to consider. Given the tremendous success in treating childhood malignancies like Wilms tumor and neuroblastoma, we have created this massive population of long-term survivors. We must now grapple with the increased risk of these survivors developing second primary tumors, things like bone sarcomas, leukemias, or breast cancers decades later, due to the necessity of the aggressive radiation and chemotherapy they received as children.
It's a huge challenge.
So the question for the next generation of pediatric treatment protocols is, how will we evolve to maintain these high survival rates while minimizing these tragic, long-term therapeutic consequences?
A vital question for future research, ensuring that the cure itself does not become the cause of the next major threat.
Thank you for joining us for this deep dive into pediatric pathology. We'll see you next time.